Hello, everyone, and welcome to today's webinar, The New Reality of the Medical Staff Office, Centralized Credentialing and Enrollment. We're so excited you've joined us, but before we kick things off, I wanted to go over just a few housekeeping reminders. First, we're broadcasting live, and we're using the GoToWebinar as our meeting platform today. To minimize your background noise, all attendees are on mute, but we'd love for this to be as interactive as possible. So please engage with us via the questions section of your GoToWebinar control panel. Go ahead, drop your questions as you have them throughout the presentation, and then we'll have some time at the end to address those together. And finally, we do ask that you participate in the webinar survey that will launch in your screen after we end today. We're always looking for ways to improve how we engage and make our time together the most meaningful. With that, I'm going to kick it over to our host, Anna Aratunian.
Today. My name is Anna Aratunian. I am Vice President of Credentialing and Consulting CDO Operations at Simpler. I joined Simpler a few years ago through their acquisition of Tract Manager. And at Tract Manager, I worked with the team there to help found the CDO. And as a part of that work, one area that we identified immediately as a market need was the need for expertise in consulting. So we started a consulting division, and it was through my capacity as a consultant that I had the privilege of working with Belinda and Robert Wood Johnson. So with that, I'll pass it over to Belinda to introduce yourself.
Hi, everyone. I'm Belinda Doyle-Pugliese. I am a Senior Director of Managed Care with the RWJ-Barnabas Health System. And as Anna mentioned, started working a few years back, working through our system-wide centralization, which we'll be talking more about and sharing some examples throughout the next 45 minutes.
In that system-wide centralization, of course, we proceeded with the development of a delegation program, the implementation of a delegation program, and we'll talk about how delegation is so critical when you're evaluating your onboarding process as a health system and attempting to centralize like functions. At Simpler, just really briefly, we provide a number of solutions. For those who are not familiar with Simpler, our focus is in a number of areas of healthcare. We provide solutions from software to services. Today's focus is, of course, going to be on our provider data management solutions, specifically in the consulting area, how we've worked with Barnabas, what we've done, and what best practices we can transfer over to you all as you take this massive endeavor on. We provide solutions for a number of areas: performance management, provider directory. Directory becomes important as we're talking about onboarding and data. So a number of areas. Our focus today specifically is going to be on how the medical staff role is evolving in response to a number of market pressures. We'll try to understand what some of those market pressures are and how they're pushing organizations to think of innovative ways to make their processes more efficient, their operations more clean, consolidating like functions, and really evaluating how they can leverage their payer relationships to impact their revenue and their capacity to generate revenue very quickly. And delegation is important for that. In the context of all of these pressures and all of these changes, we'll explain how the medical staff office, at least the role in most health systems, is now expanding. Right, the expectation for MSO is gargantuan as it is, with the possibility of taking on some additional work related to the managed care side of the business. It's important to understand how that's affecting medical staff, and what we're seeing is solutions to make this transition to a more centralized model more effective, more successful, and more comprehensive. I think a lot of organizations don't realize that they don't know what they don't know. And it's not until you start asking all of these important questions you identify that there are so many different people involved in this process. So our agenda today, we'll start with market trends. We'll focus on delegation, provider onboarding solutions, and then, of course, talk about how the MSO, as it pertains to the credentialing component of the process, is expanding. We'll have some time for Q&A, and we do have some resources that we will share with you to take back to your organization and evaluate some possible solutions for you as well. before we dive into to the presentation, we do want to take a very quick poll. And the intention of this poll is, first of all, to make sure that we are providing information that's relevant to you. So if you can please address the first poll question, which is what best describes your organization's current approach to credentialing, privileging, and enrollment functions. We have centralized these functions under the medical staff office. So whether you are taking on the credentialing for the managed care piece, or you already have, you're in the process of centralizing some of these functions within the MSO. You're exploring centralization, but have not yet started. Or today, within your health system, your managed care operations is entirely separate from your MSO. So if you can take a few moments to take that.
All right. And it looks like our results are 47% are operating at this time as two separate, with 33% of you actually already with some of the centralized functions under medical staff. So look forward to some of that dialogue for which pieces where responsibilities fell later in the presentation. We've got 12% in the process of reviewing centralizing under the medical staff, and then 9% of you exploring centralization, but really have not started yet. So I think you're gonna see a little bit for each of you throughout this, even for where you can go back and kind of always keep learning and looking for new pieces to evaluate and work together between managed care and medical staff.
From my experience working specifically on projects like this, no two organizations are the same. We're going to try our best to cover as much of the variability across health systems as possible. But if you are already in the process, then you'll know exactly what some of the pains that organizations are dealing with, whether it's policies and procedures, the nuances within each of the processes that make such massive differences. But the reason such a high percentage of health systems are in fact in the process of doing this, so quick math, I think it was just over 70% of those who are attending have either centralized already or some way have taken, the MSO has already expanded. So needless to say, you probably already understand what's forcing a lot of this. We've seen consistent increases in operational costs that just put a lot of pressure on health systems. With tightening margins, of course, the need immediately becomes to evaluate how they can impact the broader process of onboarding most effectively. Workforce shortages, right? So this is both at the administrative level for health systems, right? Finding the right staff to take on some of these additional functions, but it's also on the provider side as well. So health systems are on a crunch to access providers more quickly, to be able to generate revenue, to cushion some of those margins, to relieve some of the stressors. So given a lot of the changes in the industry, whether it's uncertainty with policies, Medicaid difficulties, a lot of compliance concerns with Medicaid and managed Medicaid, there's a lot of turnaround times, and we'll talk about what that means for the MSO, but it is extremely impactful. So all of these different changes are really forcing health systems specifically to look at their onboarding process, right? So there's a lot of pressure to onboard more quickly. We hear that every day with our clients. We need this done yesterday, right? So it's about what are thoughtful ways of getting ahead some of those delays that you as a health system already are familiar with. Focuses on technology a lot. We're seeing that it's simpler. A lot of organizations expect technology to do a lot more. There's a lot of compliance and policy around how organizations use technology, how they track those changes, how they can evidence what they do. So we'll talk a little bit about that as well. But in summary, we've got very tight margins. We need clean, efficient onboarding and operations. And therein comes delegation and onboarding. Delegation creates a really fundamental change in how you enroll a provider. In non-delegated models, most health systems, for every single provider outside of the hospital walls, right? So when we're talking about enrollment, we're really talking about outside of the hospital walls, what's happening in the outpatient, non-acute area of your health system. In non-delegated enrollment, each practitioner you onboard, depending on the number of payers you have to submit an application. So needless to say, there's a lot of administrative work, a lot of paperwork, and a lot of delay. What delegation allows you to do is take on that component of the enrollment process that really does create the delays from the health plan. So the health plan delegates the credentialing to you as an organization, which means you're now in control of these turnaround times, when applications are received, how they're processed. And that takes us to the evaluation of the onboarding process. So having delegation first before you start evaluating how you can centralize and onboard is really important as well. Effectively, the impact is massive. And I know this is Belinda's favorite topic as managed care. So
favorite slide. You can tell them in the finance division. And Anna, if you don't mind, I'm just going to ask you to go back to the previous slide for one moment. I just want to make sure everybody is noticing. So just even that first piece, so where the 47% that of the half of the attendees that did respond to the survey were saying you're operating as two separate. So when you're non-delegated, you're seeing 90 to 180 days to get through all of your enrollment for a net new practitioner. When you're delegated, you can expedite that and get it down to 30 to 45 days, if even possible less. We're going to come back to those time frames because as you centralize, you've got to share information and you've got to tie in with your MSO's rules as well. So we'll kind of come back to those time frames as well. But that leads to then what Anna had showed you, which is a return on your investment for realizing with delegation. So if you have 10 new practitioners in your practice on an annual basis, just 10 new ones, depending upon your organization's size, obviously this is an extremely small amount. And just using a basic mid-level Medicare code, and this is a Northeast New Jersey kind of market rate at the 6810, 18 working days, you can very quickly see for 10 practitioners, there's the opportunity to have $1.8 million lost, that if you're not moving through getting your practitioners into your payers quickly. So we just always want to share that for anyone who's going through that delegation process and looking for financial justifications for becoming delegated with the payers, and then again, getting more cost efficiencies by looking to then combine in with your MSO.
For organizations who aren't delegated, and if you are listening to us today, I highly encourage you to evaluate delegation, whether you qualify for delegation, what it entails, and if you have the bandwidth to take it on. That really is one of the most effective ways of impacting these turnaround times that clearly have such an impact on revenue as well. In summary, in taking this on from the health plan, you are guaranteeing or attesting or that your program meets the requirements of the health plan. Now, this is important because it translates to how this is impacting the MSO, right? So if the health plan has a specific turnaround time upon receipt of an application, and the MSO is now taking that over for your health system, well, now the MSO is under that obligation as well. So knowing what your health plan distribution is, what the different requirements are for each of those health plans is important so that you can incorporate it into your process. Under managed care, though, to become delegated, you have to have a fully vetted operations, policies and procedures, a committee, the proper licensure through primary source verifications. We're covering all of this in detail because what you'll notice is that what you are obligated to do under managed care delegation is very similar to what your medical staff is doing. And that takes us to the broader evaluation of the onboarding process for opportunities of efficiency. So onboarding is effectively taking a provider and getting them in front of a patient, not just in front of a patient, but in front of a patient that they can then bill and then generate revenue for. There are a number of functional teams involved in the broader onboarding process. Having worked with organizations on these fronts, no two organizations, again, are the same, and different players come in, right? In some organizations, the managed care is really involved in the actual act of enrolling a provider, and others, they're not. They simply do contracting. So it's important for you as an organization to identify all of the individuals involved in getting a provider recruited, LOA, executing an agreement, through HR, through risk management, through hospital privileging, through enrollment, understanding what each of them are obligated to do, what their output is, and having that big picture. So then you can start moving things around. So so-and-so is doing the exact same thing. What opportunity do we have to centralize that? We're seeing a lot of opportunity, again, within the managed care delegated enrollment, and the MSO. And this is where all of the changes and expansions are happening. So credentialing specifically for medical staff purposes and credentialing for managed care, they follow the same basic 4 process categories, right? There's an application, primary source verification, a review and decision by a committee, and then ultimately you get to see patients or access members. And in evaluating how this is going to be transitioned to the medical staff office, you have to make a lot of decisions. What is your application source? What are some of the required notifications from payers that have to go into an application? And Belinda has extensive experience with this. So Belinda, I'll pass it over to you to talk a bit about the complexity that's introduced in the application process.
So with the application process, sometimes some folks look at it and just think, okay, give me your medical staff application, give me your application for what we refer to as our credentialing provider network, or CRPN, that is our delegated entity that is accredited through NCQA and therefore used to delegate credentialing with the managed care payers based off of our organization's network service agreements. But when you're looking at that, it's combining that application and looking at the different pieces. So we have pieces that are required because of New Jersey Medicaid rules and regulations that add additional documents that the medical staff office never had to have as part of the application. But it's that willingness to sit and work together and say, okay, do our attestation authorization, like the professional questionnaire, match up? Where do they overlap? Where do they not? And if some medical staff offices sometimes look back further than what you might be used to doing as a managed care team. If your medical staff is required to have a more strict look back period, or a payer requires it, you've got to be willing to combine that and look at that in your application for what questions you need to ask in that professional questionnaire for how far back you need information. So it's those nuances as you're putting it together. For us, we have 4 separate documents, all because of managed Medicaid in the state of New Jersey. So as the managed care piece coming to the table, you need to know your state rules and regs and what application pieces your credentialing team is doing for enrollment. Sorry, I shouldn't say credentialing, that's the PSV side, but for that full individual enrollment, what additional applications are needed so you can ensure you have them as part of that application process. That's where the nuances start, even from that very beginning.
Yeah, so within step 1, step 2, and 3, and step 4, right, there are nuances between the medical staff and managed care. And PSV, this combines the requirements for medical staff and managed care. So, and that's effectively what's happening, right? The scope of the PSVs expands, the scope of the applications, the complexities. All of it is worth the investment, not least because of the impact it has on lowering cost of operations and really expediting and making this a cleaner process. And we'll talk about data as well. But effectively, what health systems are looking to do is become a far more connected enterprise. And this means technology, right? So for health systems that have siloed technologies that don't communicate well together, their managed care might be on a different system, their med staff is on a different system. More and more, we're seeing everyone combining. So taking those massive data sets and combining them together, and of course, the consequent work. When you centralize credentialing, there are a few areas that immediately you anticipate are going to have differences. Your target provider pool is one of them. So what you'll see here in this diagram is what we call primary entities, right? So the health plan is considered a primary entity in that it is obligated as a health plan to complete a credentialing process. The same with a hospital. Hospitals are under legal obligation to vet and ensure the competency of their provider, of their medical staff. So they are both considered primary entities that have an obligation to do credentialing. Now, the health plan can delegate that, right? And that's where the delegation comes in. Once it's delegated, now you see the provider network, which is all of everything that's happening outside of the hospital system, turning to the hospital to coordinate and work and leverage some of the work that's already being done there and consolidate. But the demographic, the provider pool is different. For a medical staff office, you're working with providers who are required to have privileges within a hospital setting. Not all provider types within a health system are required to have privileges, which means that there's a huge pool of providers that the MSO staff did not traditionally credential, but now they are expected to credential. We've talked about application source. NPDB is very important. In a delegated model, the entity that's licensed with NPDB needs to match the delegate, right? So as you're centralizing these programs, you want to evaluate, well, if you do have delegation, who owns the NPDB? Into your MSO, chances are you might be running two separate NPDBs for a provider because you're supporting effectively from an administrative perspective two separate programs. In brief, the impact on the MSO is fairly substantial, right? So a lot of MSO folks right now are working with technology, implementing new platforms, collecting and sharing documents with other key stakeholders, and the scope of those documents have expanded. They're asked to comply to completely different regulatory requirements than they're used to. They're conducting additional verifications, and in some instances, we are seeing that the MSO is being asked to submit enrollment rosters. The timeline here is important. Belinda, if you want to chat about the timeline on this piece.
So as I mentioned a few slides back, and we're going to come back to these timelines. So medical staff credentialing, we find it takes 60 to 90 days on average from submission of an application. And as we mentioned, full individual enrollment with payers can take 90 to 180. When you're delegated, we can get it all the way down to 30 to 45 days, or if you need something expedited, even 2 weeks or less. But now when you're tying in the differences with your medical staff office processes, they need 3 peer references, they have the health check, they are going sometimes through a 2 or 3 tier process for approval between a cred committee, then a med exec committee, and then possibly even a board review. So taking into account where those processes are is going to impact your timelines for what each party has been doing. So can medical staff office timeframes get more aggressive? And from a CRPN perspective with the payers, can you handle having a little bit longer of a process? Where do you meet in the middle as you're starting to walk through these differences, and in putting together updated policies and procedures that match up again with those applications, all of the intake? And as Anna mentioned, are you still meeting all of your joint commission for MSO? And are we still meeting all of our NCQ and or URAC, depending upon accreditations you may have with the payer, with NCQA or URAC for your payer delegation?
With that, we're going to jump into a quick poll. Again, we are really interested in understanding what your biggest challenge is in moving to a centralized model. For those who have or are in the process of doing so, if you can take a few seconds to respond to this poll. What we hear is really understood that the difficulty for most organizations is, do they separate the medical staff credentialing policies and procedures from the managed care? Do they combine it? My recommendation in working with large health systems is to keep them separate. You may very well be leveraging the same committee, by keeping them separate and separate MPDB, separate policies and procedures really helps mitigate some of the confusion, at least in the initial transition phase, as the MSO is taking on a lot of this additional work.
Okay. And obviously we're seeing 47% is the resistance to change from staff or leadership. And the other three are, lack of clear policies and governance, the uncertainty around roles and responsibilities, and have not initiated is all coming in around 26%, with 21% incompatible technology or systems. So it's kind of that stepping back initially and looking through where you can overlap, and obviously having one system, having managed care already be on that path of centralized enrollment and delegation also helps bring it together. So I know, Anna, we're going to jump into some more of the details in the next slides, but I do just want to take a moment based on everyone's response from this part of the survey, just to say that it has been a journey. I refer to it as a marathon, not a sprint for us. Our medical staff has been spending several years coming together and putting everything together as medical staff. We were coming together. We had 6, 7 different areas that were overseeing credentialing. Several years ago, it was centralized under managed care, and everything comes in together. And we had been on that journey. We are finally ready in 2025 to really mesh everything together, and have been watching and working together, though, as each other centralized their pieces. And I know Anna has a client that I'm familiar with right now, that I previously have worked with some of their facilities myself. And so they're doing everything all at once, and that is feasible as well. Again, it's the buy-in and making sure everybody has a clear vision and understanding of what the end result is. So Anna and I, we provided some additional resources from some other presentations that there are 2 handouts, which I think are a good springboard for looking at some other materials for how to put together those individual pieces, plus look at how it all comes together, because you need the buy-in from both sides in order for this to work. If I were to sit here and say to medical staff leadership, no, I'm not going to work with you, I want it all, you've got to do it my way, obviously that is not going to work. So you do need to start with those 2 key areas. And sometimes we have had consultant in, Anna has consulted with us, we have had people come in and help step in and help decide which way things should need to go. So I'm also going to keep saying, let the experts come in and help. So you need your MSO experts, you need your managed care experts. Sometimes you might need an external expert to help you decide what looks best for the model for you as an organization. So, Anna, I'll let you jump in here.
Yeah, thank you, Belinda. So really want to take some time and focus on some of the data and the application intake impact. Again, we talked about how the provider groups are different, right? So you've got outside hospital walls, your non-acute provider types who may not need privileges that need to go through this process. A lot of MSOs have electronic applications. A lot of your outside of the hospital walls providers subscribe to CAQH. So taking a customized initial appointment, reappointment application, and potentially expanding that to include other provider types. Keeping the packets separate. I've done combinations of both with different clients. I always want to make a recommendation, but there really is no one way of doing things, right? It depends on the complexity of your organization, the distribution. We always encourage a CAQH PO license, not least because it gives you immediate access to the back end of the provider's applications and data. That makes it much easier for the MSOs to be able to access applications. So it's important to determine what your application source is going to be. Your privilege packets generally are through your technology, right? So making sure you're pushing your privileges out, having a single packet per provider type. With one organization, we ended up having 5 different packets because of their provider distribution. Behavioral health providers might have different forms, even if you're delegated, that they're required to collect. So making sure that you pay close attention to how you are tracking the requirements for an application, both keeping in mind payer-specific forms, what you need from a data perspective to collect, so that because now these organizations are now on a single system, a lot of them are data sharing. So the MSO team is sharing the data they're collecting with the managed care and vice versa. This creates a lot of problems with the client I'm working with right now. When one person made a change, it affected the other. So it was really important to understand, what are your user groups? What should each user who's accessing this single system be allowed to do? Does it make sense for their roles and responsibilities? So going back to the previous pretty flower that's actually indicative of a very complex process, you want to understand what each of those stakeholders need and how you can incorporate it into an intake process. System maintenance is really important, right? If you're taking on managed care, that means you are likely going to be audited by health plans. Health plans comply to NCQA or URAC. NCQA recently has released, and these regulations changes will go live in July, more strict requirements around data integrity. So MSOs previously were not required to track certain things like, was this completed on this date? Did I receive it on this date? Did I request this information provided on this date? For a managed care perspective, that becomes more strict. Right. So things like when you received an application, who touched it, what changes they made, all of that needs to be tracked, not only for data integrity, but also for turnaround time measurements as well. So the MSO, who before was not obligated to track a lot of things is now obligated to. So you need to understand what those downstream requirements are.
And
Um,
I do
yeah.
just want to throw in about the data integrity component as well. If you're dealing with payers and you're dealing with NCQA, in evaluating a shared system between the two entities so that there's the PSV modules as well as your tracking for your enrollment and your payer components, you do want to look at systems that are, it's referred to as SOC certified. It does help with all of that data integrity components with NCQA requirements, and especially with managed care payers, depending upon the state you're in and which payers, the blues really do look at that SOC certification of your system that you're sharing.
And one of the things that we spent most time on with Barnabas was, in fact, this data infrastructure. Taking all of the managed care data, the data that payers are interested in, because again, going back to directory, all of these things get published in the directory. We spend a lot of time with Barnabas fixing data. It's not street, it's not STR, it's ST dot, right? And you might decide it's street, but it depends, right? So you want to make sure that you understand what the obligations are from your payers. Some of them are very specific about how they want this data tracked. And if you're data sharing, well, guess what? If you're responsible for data entry, now you have to comply to the requirements of the other stakeholders, and that's managed care, and that's where this comes in. So taking the time to develop a data dictionary, how folks will use your system, what they're allowed to track and not track, et cetera. So one of the areas that we know specifically for enrollment is really important are elements like whether or not they're participating with Medicare, Medicaid. A lot of MSOs have already over the past few years started to track a lot more of this information because of the revenue impact, right? So the second dollars are at risk. There's a lot of focus on these things. So now with a more centralized approach to these operations, health systems need to keep this top of mind. Tracking practice locations, right? So again, Belinda and myself and the entire Barnabas team, we went through thousands of lines of data to identify, you know, what needs to be changed, what goes into a data dictionary, and we went ahead and implemented those. Belinda, did you want to jump in on this deck here to talk through?
Sure. So this here is going to be, so for the detail, obviously your primary source verification, and it's going to tie directly into your impact. As Anna has already mentioned, there are sometimes differences between the PSV for what needs to be done. One thing that always stands out is what's we've heard as Social Security Death Master file. It's not something Joint Commission requires, but it is required of us with our payers with NCQA. You get that complexity of the fact that there's different types of practitioners that are coming through for your PSV. A lot of medical staff don't have your master's or your doctorate level behavioral health practitioners. They don't have to primary source verify PTs, OTs, STs, but you do, or genetic counselors, because they're now coming through, and they also are part of whether it's your ACO, your medical group, your SIN, some sort of a QIP program through Medicare value base. You suddenly have practitioners that are coming through at levels that medical staff does not always need to. So that ties into your PSV listings, as well as the timing to get through everyone, and also with those stricter requirements on what needs for turnaround times, such as NCQA going to 120 days now from deeming a completed application. So I just walking through those, and I think that kind of hits the higher level points. The other thing that MSOs may not be used to doing is all of the additional audits, because of the fact that if you are delegated, you're going to have annual payer delegation audits. Depending upon the payer, they'll pre-delegate audit you, and they'll ask you for files to review in one of the NCQA formats. But some payers, they don't do the file audit during your pre-delegation, and instead they want to ask you to do files during your annual delegation audit. going to suggest from the managed care side, really talk through that with the payers for what you do or don't need to do, especially if you are NCQA CR accredited yourself or working with an entity that has some sort of NCQA CR accreditation or CVO certification from NCQA, because that's going to also impact. One good thing is that both parties now, with new joint commission, you're allowed to do recred every 3 years instead of every 2, which has always been what it's been on our managed care side with NCQA and the payers. But obviously for this slide, as well as the previous, it's going to be determining, and additional resources to support might not mean additional FTEs. It might mean doing an analysis and interviewing each other's team members, helping interview each other's team members for where you now need to blend your teams, depending upon which pieces for designating responsibilities, where you're going to leave everything.
That's spot on, Belinda. So what we've done with one of the larger clients I'm working with is, in fact, we did create a hybrid team of their MSO and some of their provider-facing recruiting physician group teams. And it's this hybrid team that really serves as the concierge. So you have the provider-facing, and then you have the experts in the background doing the credentialing piece. But they've tagged team to do this. In that model, they are essentially leveraging the MSO to do the primary source verifications, but as it pertains to provider engagement, we've created a hybrid. So that's a fantastic call out. The other area that's really important, that's a big change, is the clean file policy, a clean file approval procedure. Whereas in an MSO, all files go to a committee. In a managed care, you can have a clean file. Keeping them separate allows you to take advantage of some of the efficiencies, the less strict structure of the managed care, in addition to just mitigating some of the more legal concerns, the complexities with appeals and a lot of things that come into play. So keeping them separate allows you to really preserve the integrity of each one of them, at the same time leveraging the same team or the same staff and the same data across both. So the more broadly, right, a lot of the MSO and taking on the credentialing, like Belinda mentioned, are also now taking on the policy update. So if you are keeping your programs separate, which is what we've recommended with the larger health systems, then you are once a year, as updates happen, maintaining 2 sets of policies. 2 sets of policies, 2 sets of committees. In some instances, health systems have created a centralized credentialing committee that then relays the decision to the corresponding MECs and the governing committees of each of the facilities. In another instance, with 31 hospitals, of course, it makes it very complicated. The medical staff approval process, this organization felt it was most appropriate to leave the approval process of the medical staff within the facilities. However, they have created a single centralized managed care that does the credentialing within the MSO for all of their hospitals. So there are different ways of addressing all of these demands. But effectively, the MSO, as the experts, is being asked to take on the responsibility of maintaining the policies and procedures, ongoing monitoring, reporting to health plans. So all of the requirements that come to a health system from the health plan, the MSO is taking on. And of course, that generally does mean additional resources, which is where some of the pushback comes in my experience. Having said that, the ROI of this sort of a venture is massive, and that's really where we've had success with some of the executives and really implementing some of these changes, is because we've been able to demonstrate that this does have a very significant impact on revenue and speed to revenue. In this next slide, and Belinda and I, in really putting this together, we wanted to make sure we gave you sort of a full scope image, a picture of all of the different components, the different functions, and kind of like you would play the game of matching, you know, the different items to a category. This is sort of the exercise that we do with our clients, right? So we identify everyone, we make a list of the responsibilities, and then as we cross match, we make the determination of whether or not this makes sense to be a hybrid, how technology comes into that, et cetera. But effectively, the requirement is, of course, making sure that you have created the record, that your system is clean, that you're triggering the appropriate requests for credentialing and enrollment. Ongoing and sanctions monitoring is being done effectively. On the MSO side, specific to facility functions, you have all of the MSO related work that this team is still expected to do. And now they're taking on a lot more work. So echoing Belinda's comment about additional resources, this again becomes a bit of an uphill battle, but the ROI does demonstrate that it is a worthy investment.
And then I'm just going to say on the ROI, obviously, if you already have managed care working through central enrollment or moving already into delegation, and then you have your MSO, again, it gives you an opportunity to evaluate both budgets together as one where there can be that overlap and sharing, and maybe resources from one needs to go to the other or vice versa. It doesn't always mean you have to have new FTEs, but obviously if all of this is new to you as an organization, it is going to be very difficult not to add FTEs or have to consider whether or not the FTEs you have, if they were doing provider enrollment, the payer enrollment side, whether or not you can do education and training and get them up to being more of an advanced credentialing specialist who fully understands primary source verification. We have found that individuals who have more MSO background and experience with primary source verification move much more quickly through even primary source verification from a payer perspective under NCQA guidelines than possibly an individual coming in who has 20 years of experience of doing individual cred, because they've never had to put on that investigative cap and really hunt down and go to different websites and do all of that primary source verification. So just something to take into account when you're looking at FTEs and needs for putting together your ROI. And in other sessions that Anna and I have done, we have shared with NAMS, usually the recommendation for medical staff is 1 FTE per 500 practitioners, versus MGMA gives you 150 practitioners per FTE because you're maintaining CAQH and all of that individual enrollment. So you're going to have to find that blend as well, which again helps you then possibly not have to hire FTEs, but re-educate and direct and determine which FTEs can move into which pieces for you.
So in developing the future model as we describe it, these are really the areas that you want to make sure you have full coverage, because it's within these areas that we have critical functions to ensure a provider is properly credentialed and enrolled. As it pertains to the delegation program with the MSO taking that on, Belinda mentioned this before, that usually means having one or handful of audits a year to having nearly 30 to 40. In some instances, depending on how many markets there are, you can have up to 50 or 60 audits a year. This becomes a fairly sizable function to take on. It's important to prepare the documents, the files, understand what the requirements are, coordinate with the health plan, submit them. So the auditing function becomes really important. What we've done with larger health systems is we've created a QA department within the credentialing, the corporate credentialing program, and they provide full audit support. They're the front line with payers to ensure that everything is done timely. The managed care committee is another area, right? So it's important if you're delegated and you're centralizing to make sure that you're preserving the integrity of the delegated program, and that is the delegated credentialing committee. For most organizations, again, that is kept separate. If you decide you're going to centralize your credentialing committee across your MSO facilities and your managed care, that's feasible as well. We've done that before with the client. But of course, you want to make sure that you delineate as you're having those discussions, what is managed care requirement, what is medical staff. If you decide to keep it separate, assuming you have one delegated program, I have a client who has multiple delegated programs, and our work with that client is to centralize their delegation into one, and then centralize that delegated program into an MSO operation. So like Belinda said, for most health systems, this is not a sprint, it's a marathon, because of all of the steps that are needed to position you for this effectively. Medical staff will take on some of the functions of the managed care committee as well, and in some instances, the enrollment. It's important to understand that in delegation, the only health plans that will enroll are your managed, are the health plans, right? So straight Medicaid, straight Medicare will not delegate. So in centralizing, one of the things that we always keep in mind is, okay, well, who's going to do the Medicare and Medicaid enrollment for these providers? Assuming you are fully delegated, you still have to do those unique enrollments. So if the MSO is taking that on, that becomes an even more significant expansion of their role, right? Because now they're no longer credentialing, inviting quality of the file, but they're actually doing Medicare and Medicaid enrollment. We recommend against this, not least because the MSO, their responsibilities are expanding so quickly, that having a separate group, a separate set of experts that do your Medicare, Medicaid becomes important. And Belinda, we know this from experience. If you don't do your straight Medicare, Medicaid correctly, you're going to have problems with your enrollments for managed Medicare and managed Medicaid. It is a requirement.
And Anna, I'm just going to jump in here because Carrie had asked a question. She's an MSO already responsible for provider enrollment. They're not doing delegation right now, but if they were to start, do they have to have the practitioners fully through the board before an approval process before submitting to the insurance companies? So this is where what Anna spoke about, and I mentioned, you may have a separate provider credentialing committee for your managed care side than from your MSO side. We do, and we will be maintaining that even as we merge more together and sharing PSV, because the MSO has that multi-layer for approval, whereas our practitioners to go out to a payer just need to be approved by our CRPN credentialing committee. And in NCQA guidelines and as well as with the payers, they allow you to have what's referred to as a clean claims committee. So you can have a subset of your payer credentialing committee, which we do, and it's 3 to 4 practitioners, and on a weekly basis, we're able to email them a clean claim listing. They review it, and the credentialing committee chair is one of those physicians, and he simply has to sign off after everyone else they've reviewed. They have their discussion. It's all done via email. It can also be done via within systems if you're having that shared system. But basically, they then are par. So practitioners who don't need to wait for MSO are not waiting to get in. But there, again, you need to know your payer and your state guidelines. We can't put anybody in front of our CRPN credentialing committee if they do not have their Medicaid number. Our CRPN credentialing committee also wants to know, because ours is more of a closed network where they are all employed and or contractually affiliated with us. So they want them on one of our medical staff. So if someone is net new coming in and not on a medical staff yet, they do need to wait for that medical staff. So that's where you've got to look at what is going to work best for your policies and procedures and your organization. So the answer is yes, they cannot go to a payer. The credentialing committee has to review them and approve them, but it's which committee is doing that. And if you have it separated out, MSO process first, payer, that CRPN process, you can get through that a little more quickly. And that's where you're putting here for what Anna's speaking about, for where your division of responsibilities would fall to.
That's a great call out and a fantastic question. There is strategy to this, and I think it's important to, the context of the discussion is that there are pressures, right? The margins are under a lot of pressure, and so the focus is to preserve and generate as much revenue as quickly as possible. So to that end, understanding what creates delays in certain provider types, and asking the question, do I need to take this and expand it to all provider types when it's affecting only a small group, right? I think my default is where you can, you have to standardize what you're doing across all provider types, except when it creates delays that impact revenue. So if you're holding on to a file because traditionally you as an MSO wouldn't do certain things until something was done under a managed care environment umbrella, that may be different. So thinking about, well, what's the revenue if I were to standardize it in this way? What's the impact on the revenue? Because again, that's a really important call out. Sounds like we've gone into some questions, Belinda. Are there any others that have
We
popped
do
up?
have one more. We do have one more, Anna, but I think you I just want to make sure we had made it through this slide. So the next question is from Melanie, and it's about data integrity. And Melanie, here is going to be where Anna, it's the recommendation to have a system. That's why I said SOC certified, so it can track changes, but also so you have different levels of security capabilities. So Melanie's question about how do you keep peer protected information from staff who's doing enrollment that does not need that peer protected information. And that's your security protocols in setting up the various levels of your security access in your electronic credentialing system. And then I'll hand it off to you, Anne, if you have any other suggestions on best practices for delineating security protocol between the enrollment, the more traditional payer enrollment team, and the teams that are working with the managed care delegation, and obviously medical staff privileging, where they need access to that PSV for doing the QA and cred committee meetings.
Yeah, and this is where when the two worlds collide, complications arise. Technology should be able, and the focus is, again, a lot of health systems expect technology to be able to accommodate these nuances, and it should. So one of the first things we did with one of my clients was, again, we created groups, managed care group. What do they need? What do they not need? Do they need to edit, or is it view only? And each of those stakeholders, I mean, we've got people in that system that have only view only access to certain things. In the technology that we are specifically using, you can in fact hide certain documents, right? So privilege forms, an NPDB result, right? So NPDB is extremely confidential. You want to make sure that folks who access your system have the authority to look at that information, right? So your policies need to delineate per the new standards of NCQA who's accessing, what their responsibilities are that allows them access to the system, what they can do, and monitoring of what in fact they've done. So the best way to do it, specifically with privilege forms or NPDB, is to store them. Starts with your technology. Your talking technology should be able to do this. Assuming it is, you want to separate it out based on user rights, view only or not view, hidden entirely. That needs to happen. It's important that you track that effectively. You terminate users who are no longer there, and CQA and auditing you is going to look that all of that is done. So focusing on that is really important. Hope I answered that question.
I think so. I'm going to ask if Melanie or Carrie, who we were working through those two questions, if they'd like to come off of mute and ask anything clarifying or any further questions from what we've answered.
I'm not sure they can, but I do see I do see another question. So how can MSO leaders position themselves for success when taking on delegated goodness, especially if they've never done it before? Gosh, I think, Belinda, this is the one that you may have been referencing. It's important to have buy-in, right? So the value proposition of delegation in I believe sells itself, right? So it really is a matter of taking a look at your network, assessing the projected impact of going to delegation and making that case. The dollars associated with it tend to be very effective. For an MSO leader, understanding all of the stakeholders and what they need to do, making sure that you can speak as an expert to that, making sure that they know that they can trust what you're doing, what you're recommending is pretty important. But in order to do this effectively, legal tends to come into the discussion as well. Belinda and I have had a number of discussions with Barnabas Legal. As you're developing the program, you want to make sure you're keeping in mind who the primary entity is. Is it a tax ID? What the service agreements are? So making sure that you're following the service agreement primary entity, you're incorporating that into your policies is critical to all of this.
Okay, and let me just say, I think we may have.
I see another question. Do you want to read that out real?
The number one tip you provide to an org who wants to pursue centralized model but doesn't know where to start. I think we kind of answered that already as well. So I think, Anna, I know usually, and then there also are, what are some pitfalls to avoid when moving to centralization? And it's a great question, but I think no matter how hard you try, you're sometimes going to stumble and you're going to have to take a step back, go, okay, what did we miss? What can we reassess? And how can we pick ourselves back up and move forward in trying it from another approach, kind of going back to what Ann and I have both said. This is definitely a marathon, not a sprint. And if someone, I always feel like if someone can tell you this can be done as a sprint in 3 to 6 months, it's a lot. You will be doing nothing else but this for that 3 to 6 months. This takes planning, the buy-in, the ROI, and I'm not sure if you can think of anything else, but the pitfall to avoid is just as much as you can assess up front, but you can't always do that.
And just briefly in the final 2 minutes, one of the difficult things is allowing people to let go of some of the responsibility, right? So again, going back to understanding what the implications are is really important. To the previous question, just real quickly, you do have to have a provider completely credentialed if you are delegated before you can submit them on a roster. With that, just before we drop off, if you have the time, if you are going to be at NAMS in September in Portland, please stop by, join us at our booth. It's simpler if you can go ahead and scan this and register for another webinar where our team is going to be a bit more specific about how administratively you can manage this now spike in the workload, right? So we talked about how the current environment is expanding the MSO role. Additional resources was on top. It was on every single one of those recommended slides. But are there other ways to manage this increase in workload? So on July 16th, we'll have a team to talk through some of the ways to do that really effectively. Thank you for joining us. Your opinion matters. Before you drop off, please stay on for a brief survey. And with that, I hope you all have a wonderful rest of your day. Thank you so much.
And I'm going to say thank you, Anna, for inviting me to join you again on a session. And just for the group as well, we mentioned it earlier on, the experts, if that means external or pulling in other departments you might not have thought of. You might have a development team or someone who's used to doing strategic planning, even though this may not be a new service line in your organization per se, pulling in those other resources, but look for the experts. And sometimes that is external and having a consultant coming in and working with you. We did that for several years. Anna actually just stopped working with us last year that we finally felt like the training wheels could come off. So I'll just say thank you and leave everybody with that.
Yeah.